best site to see fusion in the shoulder is in this area, the glenohumeral joint. If you see this bulge here, okay, that means there is most likely an effusion in the joint. Okay, the sublunar deformity, okay, scars, any abnormal scars indicate a previous surgery or previous operation. Okay, look for muscle wasting and muscle bulk. Okay, muscle wasting is very important. Okay, important to notice the deltoid muscle. Wasting of the deltoid muscle indicate that there is elements of disuse. Okay, look for the supraspinatus muscle, which is the muscle above the spine of the scapula. Infraspinatus muscle, also observe it. Okay, and always remember to compare both shoulders. Okay, always remember to compare both shoulders. So again, the proper exposure is the most important part. Number 2, palpation. Try to be systematic. Okay, the systematic تبدأ فين? You will start from the sternoclavicular joint. Okay, palpate for any tenderness or swelling over the sternoclavicular joint, and then you will move over the clavicle. Look for any tenderness until you reach the acromioclavicular joint. Again, any swelling or displacement, any tenderness at that side. Okay, and then you will move down below the acromion. Below the acromion, you have the subacromial bursa, which is a common site for swelling and inflammation, and a common site for impingement at that point. Okay, you will go down to palpate the greater tuberosity. Greater tuberosity is the site of the attachment of the whole rotator cuff muscle. Rotator cuff muscle, here, supraspinatus, infraspinatus, teres minor. Okay, all of these 3 muscles attached to the greater tuberosity. The 4th muscle, which is the largest muscle, which is the subscapularis, attached to the lesser tuberosity. We'll demonstrate this later on. So we palpate for this, and we'll move throughout this spine of the scapula if there is any tenderness, and then move to the edge. The edge of the scapula, and look for any tenderness throughout the joint. Okay? In the palpation, sometimes we go also to examine the cervical spinous process, because there are sometimes a referred pain to the shoulder. So the shoulder pain sometimes reflects a spine, okay, cervical spine problem, and sometimes it can reflect even elbow. So in these joints, usually we examine area of the joints above and the joint below. So after we do this part of palpation, okay, remember to palpate also the bicipital tendon. Okay, the bicipital tendon, it's in this groove. You forget it and you don't know where is the bicipital tendon, just move the shoulder like this. You will feel the head of the biceps fluctuating under your thumb. You will feel it. Okay, just medial to this is the large head of the biceps. Okay, just medial to this, we have the small head of the biceps. Okay, just medial to that. Okay, and palpate for tenderness. Okay, in that area. Bicipital tendinitis is a common problem. So, in the palpation, we palpate for tenderness, the temperature over the joint itself, and always compare it, okay, with the other side. And finally, palpate for crepitus. How we palpate for crepitus? Just put your hand on the shoulder and move the shoulder, okay, flexion, extension. You have some crepitus. Okay, so palpate for crepitus. So inspection, palpation, and then the third thing is range of motion. So the range of motion, we have 2 ways the range of motion. Number 1 is the active range of motion. If the patient is able to do the active range of motion, so this will be perfect. No need to go for the passive. But if the patient has a limitation in the active range of motion, you have to do the passive movement. Okay? Now, the active range of motion, I know most of you busy in the clinic, so we have a quick screening, okay, for the shoulder. We call it Epley maneuver. The Epley maneuver, okay, we'll ask the patient to do the following movement. Okay, okay, and then you put your hand. Okay, we'll do complete abduction up. Okay, and then put your hand, okay, below your head. Okay, and finally do like this and try to touch your scapula, okay, on both sides. This is the Epley maneuver. Okay, Epley maneuver. If the patient is able to do this movement, that means even his shoulder will be perfect. Okay, so this is the active range of motion. Okay, what are the range of motion of the shoulder? Okay, the range of motion of the shoulder.
If you do it, what does it mean?
If you do
no
it,
ligament here.
There is no problem in the shoulder. This is a quick screening test. It's a quick screening test for the movement. If you want to do it one by one, we'll do it now and we'll demonstrate. Number one, we have the flexion. Okay, flexion. Okay, and then we have the extension. So extension is around 65 degrees, and the flexion will go up to 180 degrees. Okay, so 180 degrees, this is the flexion, and then we have the extension up to 65 degrees. Okay, number two, abduction. Okay, this is abduction, and then adduction. This is adduction, okay, of the shoulder. And then we have the internal and external rotation. For external and internal rotation, we'll do 90-90. Okay? And now this is internal rotation, and this is external rotation. Okay? Easy? Repeat it? What's easy? Number one, flexion. Up 180. Back in extension. 65 degree extension. Okay? And then we have the abduction. Go up. Abduction, 180. And then go adduction. And then rotation. We do like this, 90-90. Internal rotation. And this is external rotation. Look at the shoulder. So this is the external rotation. Okay? After the range of motion, we'll test for the power. Okay. For the power, the same. If you know the range of motion, now test the power of the patient. Testing the power is like this. We'll start first with the flexion. Okay. So I'm testing the flexion. Okay. Now the extension. Okay. And then the abduction. Okay. Now testing the power of abduction. Okay. And now the adduction. Okay. So this is the power. And then we have the internal and the external rotation. And push me out. Okay. And so this is for the internal rotation and the external rotation. So I'm testing both. Come on. And now we'll go to the special test. Special test. Okay. The special test, I will try to make it easy as much as I can. Remember, number one, we have something we call it impingement. What is impingement? Impingement, that means the head of the supraspinatus, which pass below the acromion, sometimes get impinged. Okay? So testing the impingement will indicate that there's some sort of supraspinatus, tendinitis, tendinopathy, or sometimes there is a tear or calcification in the tendon. And this is a very common problem in the rheumatology clinic or even in the family medicine clinic. To confirm the impingement, we have what we call it the empty can test. Ask the patient to stand like this, okay, and empty the can like this. So, okay, and try to push, don't let me push you down. Okay. A pain in this area will indicate a positive impingement test. So, or supraspinatus problem. So this is empty can test. Number two, Hawkins test. Doing like this and face the patient. Try to do that. Just move it like this, okay, without any resistance. Okay, you will feel the pain inside the shoulder, and this is again indicate an impingement. Okay. Number three, near test. Near test, just grab the hand of the patient like this and move it up, 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 up. And remember, near the ear. Okay, you just move it near to the ear. Okay, a pain in this area will indicate an impingement. Okay. now, in this one, we examine the supraspinatus. What about the infraspinatus muscle? In the infraspinatus muscle, we do what we call it the scratch test or lift-off test. What's up here then? Okay. The action of the subscapularis can be examined by this one. Watch out. Okay. Try to lift my hand out. Okay. A patient who is able to do this movement without any pain, that means that the subscapularis tendon is intact. Okay. So we examine the most common problem. Number one is impingement. Number two, infra or subscapularis tendinitis. And now we will go for the bicipital tendon. In the bicipital tendon, as I mentioned, just try to palpate and feel the biceps, the head of the biceps. If you are not sure, just ask the patient to move like this. You will feel the head under your thumb. Okay. Now, if you want to examine, okay, for bicipital tendinitis, ask the patient just to put his hand like this. This is what we call it the speed test, as you are grabbing the bowling and doing like this. Okay, speed test, and try to resist. Okay, a pain in this area will indicate that this patient has bicipital tendinitis. Okay, a common problem. Usually you face it in the clinic, what we call it the frozen shoulder or adhesive capsulitis. The adhesive capsulitis or frozen shoulder, the patient will not be able to move at all. He has a weakness with a stiffness in all range of motion. This is adhesive capsulitis. Adhesive capsulitis is very common in diabetic patient. Okay, I'll repeat just to wrap up everything. We'll start first with inspection. Inspection, anterior, posterior, medial, okay, or at the side. Inspect for any scarring, any deformities, any rashes, or any swelling. And then start to palpate the sternoclavicular, acromioclavicular, subacromial, and then move to the greater tuberosity to feel the insertion of the head or the insertion of the quadriceps tendons. And then, okay, start to do the range of motion. Range of motion, the Epley maneuver will be the easiest way to do it, okay? In your clinic, if the patient is able to do this, his shoulder is perfect. If not, okay, do it active and passive. We have the flexion, extension, abduction, adduction, and most difficult, which is internal and external rotation. This is internal and this is external rotation. After that, test for the power.